Ladies and gentlemen, welcome to today's lecture. Today we are going to discuss anticoagulation for mechanical heart valves during pregnancy. I will request you to please subscribe to the channel and press the bell icon. So let's begin our lecture. Pregnancy in women with mechanical heart valves is very high risk and has been classified by the World Health Organization as risk category 3, that is, it carries significantly increased risk of maternal mortality or severe morbidity. Contemporary studies and prospective registries of pregnancy in women with mechanical heart valves confirm that maternal risk remains high. Maternal mortality rate is approximately 1% and the risk of valve thrombosis is approximately 5%. Given the substantial risk of adverse maternal and fetal events, there is a need for specialized expertise in the counseling and care of women with prosthetic heart valves who are considering pregnancy or who are pregnant. As far as the pregnancy risks in patients with mechanical heart valves are concerned, we can classify them into maternal complications, which include valve thrombosis, thromboembolism, hemorrhage, or even death, and fetal complications, which may be spontaneous abortion, fetal hemorrhage, fetal death, and teratogenicity. For women with mechanical heart valves, the maternal mortality rate remains more than 1%. More than one-third of women with mechanical heart valves have a serious maternal or fetal complication during pregnancy. All women with mechanical heart valves require uninterrupted therapeutic anticoagulation throughout pregnancy, and as from the guidelines, it is clear that lifelong anticoagulation with vitamin K antagonists for patients who have mechanical heart valves is a class 1 recommendation. The choice of anticoagulation strategy is challenging because there are inherent trade-offs between maternal safety and fetal safety. Warfarin is most effective anticoagulant at preventing thrombotic complications, but warfarin crosses the placenta and can cause miscarriage, spontaneous abortion, warfarin embryopathy, or fetal intracranial hemorrhage. Although low molecular weight heparin is not teratogenic, women with mechanical heart valves on low molecular weight heparin are at increased risk of thrombotic events, particularly when low molecular weight heparin is improperly dosed, monitored, or administered. There are no single optimal anticoagulation strategy that suits all women. In order to formulate a decision pathway for pregnant ladies with mechanical heart valves, the most important step is shared decision making. Also, pregnant women with mechanical heart valves should receive therapeutic anticoagulation with frequent monitoring during pregnancy, and we are going to discuss the options in the coming slide. On the other hand, if the patient is going to receive vitamin K antagonists, they should be properly informed of the risks of vitamin K antagonism. Although it has the lowest likelihood of maternal complication, it has the highest likelihood of miscarriage, fetal death, and congenital malformations. And also note that women with mechanical heart valves who cannot maintain therapeutic anticoagulation with frequent monitoring, they should be counseled against pregnancy. This is the shared decision-making pathway that should be discussed with each and every patient individually, and also not only from a cardiologist's perspective, people from other disciplines, particularly from the obstetrics unit and people from the pediatrics department should also be engaged in the decision-making process. The patient should be informed that anticoagulation with proper dosing and proper monitoring is recommended. If a vitamin K antagonists are going to be prescribed, what are the risks to the patient, and if a patient who is unable to maintain therapeutic anticoagulation for certain reasons, or if they cannot frequently monitor their anticoagulation, they should be counseled against pregnancy. Pregnant women with mechanical valves who are on warfarin therapy. At least 1 week before planned delivery, the patient should be switched to either low molecular weight heparin in twice daily dosage. The target anti-10A level for this patient is 0.8 units per ml to 1.2 units per ml 4 to 6 hours post-dose. For the second option will be intravenous heparin with an APTT or activated partial thromboplastin time of 2 times that of control. So if a pregnant lady with mechanical valves or is taking warfarin, 1 week before planned delivery, the anticoagulation regime should be changed. The patient should be either switched to low molecular weight heparin or unfractionated heparin. 36 hours before planned delivery, switch from low molecular weight heparin to unfractionated heparin with APTT of 2 times that of control. And 6 hours before planned vaginal delivery, stop unfractionated heparin. So this whole process of managing anticoagulation begins 1 week before the planned delivery, then 36 hours before planned delivery, switching from low molecular weight heparin to unfractionated heparin, and all forms of anticoagulation should be stopped 6 hours before planned delivery. If labor begins or urgent delivery is required in a woman therapeutically anticoagulated with vitamin K antagonists, reversal of anticoagulation followed by C-section is recommended. As we have discussed the management of anticoagulation towards the end of pregnancy, what is going to be the strategy for a patient with mechanical prostatic valves for their ongoing therapeutic anticoagulation during pregnancy? Let's talk about patients who can maintain their therapeutic INR with warfarin 5 mg per day or less. That is, patients who require less warfarin anticoagulation. After full discussion about the risks and benefits of warfarin, these patients can continue their warfarin for all the 3 trimesters. Patients who require more than 5 mg per day of warfarin to maintain therapeutic INR during their first trimester use dose-adjusted low molecular weight heparin with target anti-10A level of 0.8 to 1.2 units per liter 4 to 6 hour post-dose. Dose-adjusted continuous unfractionated heparin intravenous infusion with APTT of 2 times thereof control. So patients who cannot maintain their therapeutic INR with less than 5 mg means that they require more than 5 mg per day of warfarin. During the first trimester, the options are either at dose-adjusted low molecular weight heparin or dose-adjusted continuous unfractionated heparin intravenous infusion. And during the second and third trimesters, they should continue warfarin. And as we already mentioned, towards the end of the pregnancy, they should adjust their anticoagulation. However, there are certain things that should be kept in mind. The first thing is that low molecular weight heparin should not be administered to patients if anti-10A levels and subsequent dose adjustment cannot be performed 4 to 6 hours post-dose. Direct thrombin inhibitors are contraindicated in these patients with mechanical heart valves because they increase mortality and bleeding complications, and anti-10A DOACs are contraindicated. Thank you so much for your attention. I hope this lecture would help you in managing your patients. If you have any questions, please post them in the comment section. Till next lecture, thank you and goodbye.